about human and animal health, including its effects on the livestock industry. I'd like to share a few reminders before we begin. First, please be informed that this webinar is being recorded, and while speakers are in session, you may send your comments and questions to the chat box found on the bottom of the screen. Also, please remember to indicate to whom you're addressing the question to, and our question should be centered to the topic this morning. Also, in asking, you may introduce yourself, and at the end of the two-session webinar series, we will be sending a post-webinar assessment form via email, and once after you filled up and sent us the post-assessment form, we will be sending a certificate of participation to all the attendees. Now, let us welcome and hear from Dr. Claro N. Mingala, Chief of the Livestock Biotechnology Center, for his welcome address.
Good morning to everyone. Welcome to this webinar workshop. Not workshop, webinar, kind of seminar about the COVID-19 and its effects to socioeconomics. But before I will go to my message, I would like to recognize the more or less 50 participants we have now in this seminar. And I also congratulate my team in the Livestock Biotechnology Center for organizing this webinar. Okay, again, good morning to everyone. Welcome to the first webinar series organized by the Philippine Carabao Center and of course the Livestock Biotechnology Center as part of the initiative to help by raising awareness about the pandemic COVID-19. As the pandemic continues to spread, operational sustainability of food supply chains is crucial in preventing food crisis and alleviating unfavorable results on the global economy. Food and Agriculture Organization of the United Nations results on the global express that while protecting public health is the first priority, it is also necessary for the governments, policymakers, and the international community to recognize and attempt to mitigate the negative impact of the pandemic that contribute to food security, nutrition, and livelihood. Some areas affected by COVID-19 are animal production, processing, transport, sales, and consumption, of course, of public health importance. This webinar will provide better perspective about the health and socioeconomic effects of COVID-19 on human and the livestock industry. Thank you and hoping for your productive discussion, and we look forward for your participation to our future activities. I would like also to personally welcome our speakers, Dr. Castillo and Dr. Garcia, for gracing this webinar workshop. Congratulations. Maraming salamat po. Buhay tayong lahat.
Thank you very much, Dr. Claro N. Mingala. Now, allow me to introduce our first speaker this morning. Our first speaker is a graduate of Pamantasan ng Lungsod ng Manila, and she finished Doctor of Medicine. She had a fellowship training in infectious diseases in San Lazaro Hospital, Santa Cruz, Manila. She is currently a medical specialist 3 in Dr. Paulino J. Garcia Memorial Research and Medical Center. Now, let us hear from Dr. Lailani Mogol Gustillo.
Okay, so good morning and thank you for this. I'll be discussing now the basic facts about COVID-19. And so we see that today the world is actually facing a formidable opponent. We have here a virus that is so small, and yet it has caused really a very big problem for the world. So at the end of this discussion, these are the questions that I hope that would be answered. So first is, what is coronavirus? Then how did we get the COVID-19 disease? What is our present COVID-19 status? What are the symptoms of the disease? How to diagnose and prevent COVID-19. So coronavirus, so let's start with this coronavirus. Actually, this is not a new thing for us. Coronavirus has been there for so long. It is actually a nucleic acid, which is a large RNA, approximately about 30 kilobases in length, which is a positive single-stranded polyadenylated RNA. It was called coronavirus because of the crown-like spikes in its surface. We already know 7 human coronaviruses that infect us. The first 4 of which, the alpha and beta coronaviruses, the 229E, NL63, OC43, and HKU1, these are the common causes of the common colds. These are the causes of the common colds. Then we have the MERS-CoV, which is a coronavirus that caused the Middle East Respiratory Syndrome, or the MERS. Then we also have the SARS-CoV, or the beta coronavirus that caused the severe acute respiratory syndrome, and now the SARS-CoV-2. So SARS-CoV-2, I mean the SARS-CoV, the original SARS-CoV, was first recognized in China in November of 2002. China again. It had its worldwide outbreak in 2002 to 2003, and it had caused 774 deaths. But since 2004, there has been no new reported cases of the SARS. Actually, the intermediate host for this disease was known to be the civet cat, but the virus was actually traced back to a bat actually. Then we have the MERS-CoV. The MERS-CoV, okay, it was first reported in Saudi Arabia in 2012, but it also died down its natural death. It has since caused illness in the people worldwide after its report in 2012. Then we have now the SARS-CoV-2. First, we go back to the timeline when it was still happy and we were not disaffected. Our country was not disaffected yet. In December of 2019, that was actually December 31 of 2019, when we were celebrating the new year, 27 people from China were reported to the WHO with pneumonia of unknown cause. They came from Wuhan, South China seafood market. They were actually stallholders from there. A week after, the WHO were able to isolate and identify the cause of this pneumonia, and true enough, it was a novel coronavirus, and they called it the 2019 novel coronavirus, or the 2019 nCoV. Then the first death was reported from the customer from the seafood market, who was a 61-year-old male Chinese who had another medical condition. Then we saw some other cases, severe cases of this disease until I think it was 30 days, so barely a month after, we had our first case of the 2019 nCoV ARD. That was what it was called before, from a 38-year-old female Chinese who arrived in our country from Wuhan. At that time, she was admitted in a hospital in Manila. Then it took 1 month before the WHO finally declared the 2019 nCoV ARD as a public health emergency of international concern. But this time, the Philippine government issued travel ban to travelers from China, Macau, and Hong Kong. So that was January. Then February came and we saw another case of the disease in our country, one after the other, but they were all Chinese at the time. So our first case was a Chinese, second case was a Chinese, and the first mortality outside of China, he actually died. He was the partner of the first case. And then the third case was also a Chinese, okay, a Chinese female. After this, we had the repatriation of our Filipino workers from Wuhan, China. Then after that, we welcomed the Filipino workers on board our cruise ship MV Diamond Princess, which was docked at that time at the Yokohama, Japan. So these repatriated OFWs, the repatriated workers in China, they all came here and they were actually negative at that time. So the first local transmission happened actually March 6 of 2020. Two cases were identified by the DOH, both Filipinos. The fourth case is a 48-year-old male Filipino with travel history to Japan, and the fifth case is a 62-year-old male Filipino with no travel history, but he reported to have frequented I think that this is the mosque in San Juan. Then after this, the WHO the DOH confirmed that the first local transmission of COVID, this time they already called it as COVID, and the sixth case was identified as this is the wife of the fifth case. One after the other, we had the succeeding number of cases that increased in our country. And by March 13 of 2020, our COVID cases has raised to 64. And by this time, our DOH declared it as code red of level 2. As of today, this is of July 26. So we have 80,448 total cases this is our confirmed cases of COVID. But as of July 27, 2016, we already have more than 82,000 confirmed COVID cases in the Philippines with close to 2,000 deaths. Most of the cases come from NCR, Laguna, Cavite, Cebu, Rizal, and but what is quite, I would say, not that alarming here is that most of the cases are mild. Close to 90% are mild, and the 10%, most of the 10% which are not mild, 9% of that is asymptomatic. Okay, only a little percentage would be severe and critical. However, these cases are still occupying most of the hospital beds in most of our hospitals. In our province, okay, in Nueva Ecija, so we have, I think this is already 168 confirmed cases, total cases in the province. We have 75 recovered, and still we have 7 deaths in our province. Okay, most of the cases come from Cabanatuan. So what are the symptoms of COVID-19? How would you know you may be presenting symptoms of COVID-19? These symptoms may vary from fever or chills, cough, fatigue, muscle or body aches, headache, loss of taste or smell. This is first things that you would notice would be the loss of taste or smell. Then you would have the sore throat, congestion or runny nose, nausea or vomiting, diarrhea. Some cases are less than 50% of cases present with diarrhea, and severe form of illness may have shortness of breath or difficulty of breathing. Now, the symptoms of COVID-19 may appear in 2 to 14 days after exposure to the virus. We have the incubation period for COVID-19, and the incubation period would be 2 to 14 days, but the average would be 5 days. Okay, so that is the reason why we ask our contacts to quarantine themselves for 14 days. Okay, whether they have symptoms or not, they would have to quarantine themselves for 14 days, mild symptoms. Now, if they have severe symptoms, they would have to go to the hospital or any healthcare facility. The acute or mild phase of this disease, which will present with non-specific symptoms. It may be a flu-like symptom, commonly with fever, cough, myalgia, fatigue, nausea, diarrhea. This would happen in the first 10 days, usually 5 to 10 days. And the severe symptoms would present with difficulty of breathing, fast breathing. Most of this would be presenting with hypoxemia or a low oxygen in the blood. And this would precede the ARDS, problems with your lungs, and the pro-inflammatory phase of the disease, which will happen from days to weeks. Some people would recover after several months, if there would be recovery. Having said this, there are some debate that we hear, is COVID-19 a droplet or an airborne infection? In the past, the WHO would tell us that it would be enough for us to do the contact and droplet precaution on this virus, on this disease. Why? Because actually the COVID-19 or the SARS-CoV-2, which is the virus that caused this infection, is actually a droplet infection. Okay, why do we say it's a droplet? Okay, from an infected person, you see here the one on the left, the figure on the left. So from an infected person, the virus would be sucked out or sneezed out whenever a person would talk or spit or breathe or sing. The droplet nuclei would be spit out from the mouth of the person who is currently infected with the virus. The heavy and wet droplets would not actually be suspended on the air, but they would actually drop down from a distance of 1 meter to 2 meters. That is the reason why we are telling the people to keep a social distance of at least 6 feet, or that would be 2 meters. Now, there would be some small droplet nuclei which will be floating in the air once they are dried out. Now, these droplet nuclei would be the ones that will remain suspended in the air, and some studies would say that it would be suspended for a minimum of 2 hours to 8 hours. Some studies would say 8 hours, some studies would say it would be in 2 hours. When there is another person who is not wearing a mask or who is not wearing any barrier, whether a mask, a face shield, or anything, then he would be susceptible to the droplets or the droplet nuclei that would be coming from the infected person. Actually, the the size of our SARS-CoV-2, it's actually big. Okay, it's around 100 nanometer, which is actually a big size that could not pass through our surgical mask. Why do we have to use the N95? The N95 actually is reserved for healthcare workers. The healthcare workers will be the one who would be using the N95 because they would be doing some aerosol generating procedures. And what are these aerosol generating procedures? Intubation, extubation, doing the CPR, nebulization, some surgical procedures on the patient. These are the procedures that may cause the aerosol coming from this patient, and that may cause the aerosol to be suspended in the air. And this would be a reason for the healthcare workers to inhale these aerosols. As much as possible, we would want the N95 and all similar respirators to be used by the healthcare workers, because in the market, we are already seeing a depletion of this specific respirator. So in our institution, in the Paulino J. Garcia Memorial Research and Medical Center, this is what we have for our healthcare workers and for other healthcare personnel. We have given the correct PPE to be used by the healthcare workers and healthcare personnel according to the activities that they do. So you see here, not everybody will be wearing the N95. Not everybody will be wearing the gown or sometimes the bunny suit. So you see here the people in the triage and some points of entry, people in the screening area, the guards, the minimum PPE that we tell them to use are the medical mask and the gloves. Sometimes we ask them to use the face shield. We have the different types of face shields nowadays. For those who are collecting the respiratory specimens, so this is our med techs, so they use we call this the type A PPE. So with our people from the operating room, people who do surgery, and the people who perform our aerosol generating procedures. Transport aides and other workers, even if they are doing works related to the confirmed cases of COVID-19, they would use the medical mask, not the N95, not the respirators of similar function as the N95, the gown, the gloves, the goggles, and face shield. We also have here the risk assessment of our healthcare workers. We assess their risk according to the type of PPE that they use, plus the PPE being used by the patients. So if the patient, example here, if the patient is wearing mask, okay, and the healthcare personnel is also wearing masks with goggles, with gowns, that would be a low risk. So even if you will be in close contact with the patient, close contact defined as being less than 2 meters from a COVID positive patient for a prolonged period that is more than 15 minutes, even if you engage in that type of activity, but the patient is wearing mask and you are wearing mask, even if you are not wearing goggles or face shield or the gowns and gloves, that will still fall under low risk category. So the high risk category would be the patient is not wearing mask, you are not wearing mask or any PPE at all, so that would be high risk. So what will we do then? If you are under the low risk category, you will just have to check your temperature twice a day. Watch out for the symptoms for 14 days. So you see the 14 days of monitoring. So if there would be symptoms, you would have to immediately inform your superior and self-isolate. Will there be work restrictions? If you are asymptomatic, you do not have to have work restrictions. Okay, that is for the low risk. Now for medium to high risk, it would depend whether you are symptomatic. So if you are symptomatic, immediately you have to isolate yourself. You do not report to work for 14 days since your last exposure. We also have here the types of PPE to be used according to the areas. So this is another classification that we provided to our workers. If you are assigned in the accounting, okay, the legal, most offices, you would be at the lowest risk area. So for lowest risk, you need the level 1 protection. And take note here that in all levels of protection, what is the most important is the hand hygiene. The hand hygiene technique is the most important whether you are in the highest risk or in the lowest risk areas. For hand washing technique, so we know that several agencies, several healthcare agencies have shown us the different techniques with hand washing or hand hygiene or hand rub. Okay, what is more important here actually is the duration of your hand rubbing. This is the most basic of the hand washing technique. With if it is with soap and water, so we wet our hands with water, we apply enough soap, then we start rubbing. Okay, it has been said a long time ago to sing two happy birthday songs when you hand wash or when you hand rub. That is just to approximate the time of your disinfecting your hands with the soap or the alcohol based hand rub. Okay, and be sure to rub your hands palm to palm, fingers, okay, the interlacing and interlocking fingers. Don't forget your thumb, the nails, okay, the tips of your fingernails, and then the wrist. And once you have finished your hand rubbing, rinse your hands completely and use clean towels or disposable paper towels in drying your hands. Okay, that is also important. And it is also important to frequently wash your hands. In our department, we would tell the residents and other consultants to wash the hands at least 15 minutes, every 15 minutes, so that you would be sure that you completely wash your hands. We don't actually recommend or we do not encourage the use of gloves, especially when you are not dealing with touching your patients or touching anything that is actually soiled and dirty. The more that you use your bare hands for regular works, the more that you would be conscious in washing your hands. They say that coronavirus actually has staying power, okay, that it stays alive in different types of surfaces. So we see here that coronavirus can stay in copper up to 4 hours, in cardboard and paper for up to 24 hours. It can remain suspended in air up to 3 hours, stainless steel up to 3 days, in plastics up to 3 days. Well, no matter how long this virus can stay in the surroundings, this is also the reason why the other mode of transmission is contact, because some fomites may stay in the surfaces, and then when you touch these surfaces infected with these fomites, and then you touch your face, your mouth, your eyes, or your nose, then the virus will have an entry point in your body. Now, the most important of which is not to let the virus enter your body. And how do you do that? You have to do frequent hand washing, okay? And you have to clean the surroundings also, because even if this virus can stay in different surfaces, this virus can easily die due to the different types of detergents, soap, okay, even alcohol can kill the virus. Okay, so that is more important, is to keep the surroundings clean and keep yourself clean. So how to clean COVID areas? The air, the surface, environment, personal protective equipment contamination by the SARS-CoV-2 from asymptomatic patient. Okay, it can easily contaminate the air and everything that in our surroundings if your patient is symptomatic. Okay, we have different types of patient. We have the asymptomatic patient and we have the symptomatic patient. Remember, the SARS-CoV-2 is a respiratory virus. So if your patient is coughing, if your patient is having runny nose, okay, he can easily contaminate your surroundings. So how do we clean our areas? We have to do twice daily cleaning of high touch areas using 5,000 ppm of sodium dichloroisocyanurate. This is actually just the chlorine wash, okay? The floor must be cleaned daily using 1,000 ppm of this solution. And after cleaning the environment around patients, a study from this that was published in JAMA showed that after cleaning the environment around infected patients, there had been negative growth of SARS-CoV-2. But before cleaning, there was one symptomatic patient with positive RT-PCR. So even if there is a patient who is positive with RT-PCR and you were able to clean your surroundings, there would be negative growth of the SARS-CoV-2. So how do we do this 5,000 ppm solution? So the dilution for our liquid sodium hypochlorite for 1:100 for a 500 ppm solution which is being used for routine cleaning of lightly contaminated surroundings, we have 99 ml of water with 1 ml of our bleach or our solution. For the 5,000 ppm, to be able to have the 5,000 ppm, we just mix 1 ml of our bleach, the liquid sodium hypochlorite, and 9 ml of water. Now, we also have the solid calcium hypochlorite. This may also be used. If we have this, we use 1 tablet of this sodium hypochlorite to 4 liters of water to be able to produce 500 ppm. For 5,000 ppm, we just reduce the volume of water to 2 liters with 1 tablet. So how do we use the face mask correctly? A while ago, I have told you to reserve the N95 and similar respirators for the healthcare workers because they are the ones who really need that. Now, for our other people, for us, we may also use the face mask. What is important here is the correct wearing of the face mask. When we wear the face mask, we have to make sure that we cover our mouth and our nose completely. We do not wear the face mask on our neck. We do not wear it showing our nose. And we do not let children under 2 years old wear the face mask. Kasi po, when we do that, some children, hindi sila makakahinga. They won't be able to breathe properly. Remember, children are mouth breathers. So they won't be able to breathe properly. So what do we do for children who are, if we do not put face mask on them, then don't let your children go out of the house. Diba? Bawal. It's a no-no for children less than 21 years old to be roaming around as well as for senior citizens. The reason for this is once you get virus, once you get the infection, it would be a severe infection mostly for the elderly who are having other comorbidities. So when to use a surgical mask, if you are in a crowded place, in cohorted area, even if you have no patient contact, you have to use your surgical mask. If you are within 1 meter, other people, even if these people are not known positive for COVID-19, then you also have to use your surgical mask and any other face mask. In our country, it is a law, I think, that everybody should be going out of the house with face mask. If you do not have face mask, you will be fined. In some areas, fines will range from 1,000 to 3,000. Some would even fine you with 5,000 pesos if you are caught not wearing your face mask. So when to use the FFP3? Okay, we have the N95. That is a US standard. We have the KN95, the China standard. We also have the FFP3, FFP1. These are European standards. But they provide the same type of protection. So we reserve this for our healthcare workers who are doing the aerosol generating procedure. Some areas, some clinic or some hospitals would tell you, I think even salons are now bragging that they have HEPA filters in their area, in their offices, in their clinics, in their salons. So the most important thing in preventing the COVID-19 infection in your body is to avoid crowded places. If you have a naturally ventilated room, you would be able to get the recommended ACH or air change per hour with this following instructions. Okay, for offices and OPD clinics and some those areas, we have to maintain the 6 ACH, the 6 air change per hour. And for patient's room meaning this rooms of the COVID positive patients and some other rooms that wherein there could be patients with COVID positive with SARS-CoV-2, we have to maintain at 12 ACH. So how to maintain this? So in order to maintain at least 6 ACH, so we can have just the windows to the door at 50% open and door to corridor 50% open. So safe na tayo dyan. For clinics, for closed spaces, if we do not have the HEPA filter, we can just have this 50% open door and 50% open windows to door. Okay, now if we have you see that all rooms of our patients, particularly those in the government hospitals, would be having the HEPA filter, and they may not have the air conditioned room, and I think which is better if you just have the natural ventilation in your room, you just have to open your windows to door 50% and 100% open the door to corridor, and then you'll have the 12.8 ACH, and that would be the recommended ACH for the patient's room. Okay, now we go to the diagnostic test. Ito, medyo marami ding question dito. There are several diagnostic tests for COVID-19. So we hear every now and then, we have the rapid test, okay, the molecular test, okay, the RT-PCR. So which is which? We have here the molecular test. This is also known the RT-PCR. Okay, we also have the nucleic acid amplification test, the LAMP test. We also call this as the viral test, the molecular test. This test requires the nasal or throat swab. Okay, hindi po ito blood. Okay, the molecular test is a nasal or throat swab. How long do we get the results? It depends, okay, it varies kasi in the first months of COVID-19 in our country, we used to have the test result would be available from 1 to 2 weeks. Sometimes it happened, no? 3 weeks na wala pa yung test results. So, but right now, since we have a lot of diagnostic centers already, we were able to get is mga after 24 hours. That's the shortest time that we have. Is another test needed for molecular test? Usually, this is highly accurate and it does not need to be repeated. It shows active coronavirus infection. This is the only test available in our country that we use as a screening test. What it cannot do, it cannot, however, show you that you were infected in the past. This is the difference between our molecular test and the antibody test. The antibody test, kasi we have here, you see here the antigen test as the rapid diagnostic test. Kasi these slides were taken from the Western publications that doon kasi mabilis ang results. So they get the rapid diagnostic test even for the antigen test, no? And even for molecular test. But in our country, we refer to the rapid test as the antibody test. Kaya RAT, you get to see that in some requests, the RAT or the rapid antibody test. It refers to that. So for antibody test, this is a serological test. So when we say the serological test, what we are after is the amount of antibody present in our body. So how does it happen? So when you are infected with the virus, your body would take some time to produce the antibody, usually 5 to 7 days before you get the earliest antibody. And that earliest antibody would be the IgM. So once you get the IgM, once you take the rapid antibody test and you are IgM positive, then it may mean that you have the acute infection of the coronavirus. It may denote, but it may also mean that your infection could be any other coronavirus, not necessarily the SARS-CoV-2. So what we usually do is to request for the molecular test, the RT-PCR, which would tell us that you really have the SARS-CoV-2 infection and not any other coronavirus. Now, they say that the rapid antibody test would give us a high false positive and false negative test. Yes, correct. Because it will depend on the timing of your test. you see, you will have to wait a week or so before your body could develop the antibody. Now, if you subject yourself to the antibody test early on, then it shows a negative test. Well, it doesn't really mean that you are negative for the COVID-19 because it may mean that you are just too early for getting the test. It may be a false negative. False positive is, like the one I told you may have the positive IgM test, but it may not be necessarily the SARS-CoV-2. So we do not use the antibody test for screening of our patients for COVID-19. If we would like to screen our patients for COVID-19, we request the RT-PCR. This data are taken from the CDC. So this is just some data that I got from CDC that correlates the animals and COVID-19. We know that the first reported infection of COVID-19 was linked to a live animal market in China. Okay, it says that it came from the bat. So the first US case of an animal testing positive for COVID-19, that was 19, not COVID-10, COVID-19 was a tiger in a New York zoo. But this tiger eventually got well anyway. So a small number of cats and dogs have been reported to be infected in the USA, and several lions and tigers in a New York zoo were tested positive for the virus, for SARS-CoV-2. And in Netherlands, the mink were infected with SARS-CoV-2 that caused the demise of a number of mink in the Netherlands farm. So for the carabaos and other livestock, I was not able to get any data on that. And I think our other speaker would discuss that, but I was not able to get data on the relationship of COVID-19 to other animals other than this one. So in summary, so we're able to discuss that SARS-CoV-2 is the virus causing the COVID-19, which is a pandemic in our times now. The transmission rate of COVID-19 is high, but most cases are mild. So the reason why we have so many cases, because it has a very high transmission rate. The R naught is from 2 to 4, saying if the R naught is more than 1, then it says that it is highly transmissible. Now, in order to avoid being infected, these are the most recommended of the procedures. Wear our mask properly. It doesn't matter whether it is the N95 or the surgical mask, as long as you know how to wear it properly. When your mask is already soiled, you have to replace your mask. Do not reuse masks that are supposed to be disposable. Okay, wash your hands frequently, at least, I think the best is every 15 minutes. Sabi nga nung isang I think cardiologist, safe ang prading. Okay? Avoid crowded places. Okay? Do not, if you don't have anything to do outside, then stay inside. Stay indoors. Diagnosis of active COVID-19 is through RT-PCR. I think that's my last slide. Thank you for your kind attention.
Thank you so much, Doctora. Now, the Doctora Gostilo will be entertaining some questions. GL Constante from UP Manila, I think, is asking, when is the best time to test for COVID-19 antigen? When does viremia occur during the course of infections? Thank you.
Okay. So, so we go back, So we know that a patient could be infectious 2 days prior to the onset of the symptoms. This is for symptomatic patients. Okay, so the infectious period of the patient may happen 2 days before the onset of infection, and it may persist up to 14 days after the first day of the being symptomatic. So that is why that is the time when you ask the patient to be in isolation if this is a positive case. Now, if this is a contact, the same, you have to ask the patient to be in quarantine until 14 days. Okay. Now, when is the best time to test for COVID-19? it depends if your patient is symptomatic or asymptomatic. Because right now, you may not ask your patient to undergo the RT-PCR. If your patient is asymptomatic, you may ask the patient to quarantine, to self-quarantine for 14 days. Now, if the patient is already symptomatic, you ask the patient to go to do the testing right away if the patient is symptomatic. But if asymptomatic, you may ask the patient to quarantine for 14 days. Now, if there would be symptoms, you have to notify the healthcare worker, the healthcare provider right away. Now, if the patient would like to be tested and the patient is asymptomatic, you can tell the patient the best timing would be 5 days from the time of the last exposure. Okay, because at that time, that is actually according to studies, that would be the time when most symptoms would happen. Okay, when of course you are already infectious by the time that you had your contact with the known case or the known COVID confirmed case, but the viremia would happen from 5 days. Okay, that would be the rise of viremia would happen from 5 days after the exposure.
All right. Thank you for that. We have another question from Miss Erica Lapus. So as of today, what is the most effective treatment available used for COVID-19 patients?
Most effective treatment. It would depend on what is the condition of your patient. Right now, we do not have the treatment yet for COVID-19. Everything is under study. We have the Solidarity trial. We have different trials undergoing right now. We have remdesivir, the antivirals. Okay, we have anti-malarials. We have different drugs that are being under trials right now. But you would say that none of them is actually for COVID-19. These are compassionate use of the different medications, but none of them is actually we would say would be the most effective. It will still depend on the present condition of the patient. We may use the tocilizumab, we may use the remdesivir, we may use the different antivirals, the lopinavir. Okay, but still it will depend on the condition of the patient.
All right. Thank you, Doctora. And we have another question from Anne Franchette Asuncion. She asked, what can be used for the protection of infants if they need to go out? For example, they have to go to the hospital for vaccination.
Mhm. Maybe you can. I have seen some infants that who are wearing the face shield. There are several face shields, no, medyo pasadya siguro yun, the face shields that they use. But please do not give face masks to the infants kasi baka masuffocate yung
Oo nga.
infants.
Okay. We have question from Dr. Marvin Villanueva. He asked if a resident in a small community visited the hospital, either for checkup or admission, what do you recommend them to do next?
Are you referring to the kasi I have heard and I have the experience with some patients and some relatives of the patients who are asking for some diagnostic tests to be able to go back to their community as because that would be a requirement according to them, that is a requirement for their community. Is this the one that you would like to ask?
Yes,
Kasi,
po.
okay. So if they visited the hospital, okay, ganito po yun. For most hospitals in our country, visitors are not allowed in the COVID wards, in the COVID areas. Okay? I think most hospitals have actually changed their rules. Okay? Like in visitation, visitors will not be allowed in the COVID areas. Some would restrict the number of visitors. Even the the companion would be restricted to one companion only per patient. Okay, and if it happened that this somebody went to the hospital with positive cases of COVID, I hope they did not stay long with the known positive cases. Kasi not all hospitals naman po would be having the whole hospital for COVID only. There would be specific areas for COVID patients, and these areas are not for for not accessible for other patients or for other healthcare workers. So do not be afraid to go to the hospital when you are sick. You will not be exposed to other COVID patients as long as you follow the recommendations, that is to avoid crowded places, to maintain a distance of 2 meters from other people, not just your from other patients, not just from the other patient, but also from other unsuspecting uh, uh, people. And of course, wash your hands, wear your face mask. Yun. With the diagnostic tests that are being required, uh, of course, I have told you that screening using the rapid test is not advisable unless you do it with the RT-PCR. And the WHO has given us different different guidelines also, that you, re- you really do not have to do the RT-PCR. You may want to use the quarantine and isolation rather than RT-PCR if you are not symptomatic, if you're asymptomatic, or if you have mild symptoms. That would be more cost effective, since we are also having problems with our diagnostic test and our other laboratories.
All right, we have another question from GL Constante. Hello again, Dr. Gustilo. May I know the mortality rates per age groups observed in the Philippines? Is the trend similar with those observed in US and China?
Oh, I'm sorry, I don't have the mortality rate per group here, per age group. But I think with the previous trend that we have, most of the mortality comes from those group with other comorbidities. I'm sorry, I don't have the mortality rate yet, but I will go back to the group when I have it. I'll look about it.
All right. Um, Here we have another question also from Jubilee Balonkita. Good morning, Doc. What is the basis of restricting people aged below 21 years old? Are there studies saying that 20 years olds, for example, are more susceptible to the virus?
Okay, so this is actually a shall I say a political move to restrict those people below 21 years old. Okay, this is actually a directive from the IATF. Okay, basis for this, um, I think not much of a health concern, ano. But don't quote me for that, for this, ano. Kasi in other countries, in the US, they are actually just restricting the elderly, okay, because the disease is more severe in the elderly. But for the younger group, there is actually not much of a restriction. Pero siguro para hindi na lang makulit yung mga below 21. Pero the problem with us kasi, you have to also consider that our country is a poor country, and we do not have that much resources. We cannot test everybody. So the more people that we have in the streets, the more people that we're going to test. And we do not have that much capacity to test everybody. So the less people there are in the streets, the better would be the testing capacity of the country. Pero if you're going to ask me the health wise naman kasi, in the past, no, we saw that infection with COVID-19 in children is actually not that severe as compared to the adults. But then they are also being infected, so nobody is spared from this.
Yeah, exactly. Another question from Dr. Marvin. You mentioned in the presentation that majority of the cases are mild case. What do you think is the reason for this? And is this situation in the Philippines similar with other countries?
Yes, yes, yes. Most of the most of the cases are actually mild. No, but the reason for this, the virus is actually uh it has a very high transmissibility, but in terms of severity, it has not that much severity. Okay, as compared to Ebola, Ebola has a very high fatality rate, meaning that uh, mabilis siya, 'di ba? Mabilis siyang namamatay agad yung patient. Once you get infected, patay agad yung pasyente. But with COVID-19, mataas lang yung transmission rate niya, but most of the cases are mild. Nangyayari lang that it becomes severe when the patient is having another comorbidity, another disease. Patients are hypertensive, patients have bronchial asthma, patients have diabetes, cardiac problems. Okay, the reason for the death of these patients are primarily the exacerbation of their other comorbidities, and not which is being done, which happens because of the co-infection with COVID-19.
Dr. Marvin Villanueva also asked, is it advisable that if ever a person started to show signs similar to COVID-19, does he or she needs to report to RH immediately?
Report to where?
To RHU po.
RHU, yes, yes. Uh, the first thing that we tell our our workers would be, if you are sick, do not go to work. Okay, because these symptoms of COVID may be similar to the common flu. Okay, it may be similar to the common cold. Okay, so as we said, it has a very high transmissibility. Transmission rate is high. So when you feel sick, when you are already having fever, and you have a probable contact with other people who may have COVID-19. You have been to several places where there are cases of COVID-19. So there is a possibility that you might you might be having the infection. So if you already have symptoms, then do not go to work. Report to the RHU. Report to the nearest healthcare facility so that you will be evaluated properly. That is the first step towards mitigating the risk of spreading this infection.
All right. From Merus Uy, she asked, people who have fully recovered from COVID-19 have antibodies in their plasma. How can they evaluate the plasma from recovered patients as possible treatment?
Okay, so you're talking about the convalescent plasma use. Okay, there are some uh, caveats to this, no? Kasi not all people who have recovered to COVID-19 would be candidates for the convalescent plasma. The DOH have told us that for discharging our patients with COVID-19, we need not repeat the RT-PCR. Okay, this is another guideline from the DOH. Once the patient has already uh, been asymptomatic, no fever for 3 days, and the patient is doing well, 14 days had already elapsed since first uh, the first symptom of the patient, then and the medical officer would tell that the patient has really recovered, then we can discharge the patient as recovered. Okay, so no test for the repeat RT-PCR. However, if you are a candidate for convalescent plasma donor, I think they have the different criteria for this. Now, uh, there is another downside on this because not all patients who have had COVID-19 in the past would actually be immune to COVID-19 because there are already some reports of reinfection for those who had been infected in the past. So regarding the convalescent plasma, it is a long story for that. It is another, I think we have to have another webinar for that. It's long. But for the use of the antibodies, okay, the antibodies does not really last that long. It is not a uh, it's not an immunity for forever. Okay, there are already reports of reinfection.
Okay, from Miss Jessalyn again.
Ayun.
She asked, "May I know if you have encountered or are you aware of cases of reinfection for COVID-19? If so,
Yeah.
would this have an implication to possible vaccination plans?"
Yes. So as I have said, there are already cases of reinfection of COVID-19. And
Reinfection.
yes, there are already other cases. In Manila, there are already cases. And even in Western countries, they have already reported cases of reinfection for COVID-19.
All right. From Dr. Randy Tolentino. There was a US study that found out that COVID-19 patients who recovered have been reinfected, and they said that the antibody titer of the patient starts to wane after 3 months of infection. What do you think will be the implication of this if ever a vaccine has been approved for use?
Yes, that this would really be a big implication. No? Kasi this is also why we cannot this is also why we take time for producing the vaccine because we have to consider this cases of reinfection. Actually, in some areas, this is not yet reported officially, but some people in other areas would say after 2 months they have already been reinfected. So the reinfection is actually pretty.
From Doc Marvin, do you have any updates on the use of virgin coconut or for the treatment or prevention against COVID-19 po?
I think the study is still ongoing.
Answer is ongoing pa daw po yung
Yes,
study.
it's being used now in PGH. Kasi doon maraming cases.
All right. So again, we would, in behalf of Livestock Biotechnology Center, we'd like to thank Dr. Lailani Mugalgustilio for sharing her expertise and for helping us more understand the nature of SARS-CoV-2 and the impact of COVID-19 to human health. So tomorrow, we will be having another webinar session. And the start of the session will be on 9:30 a.m. Same time po. And since we have already tackled the effects of COVID-19 to the human health, tomorrow will be more on focus on the impacts of COVID-19 in the livestock industry. I guess that ends our first webinar session on COVID-19 health and socioeconomic impacts on the livestock industry. We wish to thank everyone for attending. Thank you so much, especially to Dr. Lailani. Thank you, Doctora.
Thank you.
And,
Thank you.
and thank you and stay safe po sa lahat. Maraming salamat po.